turning your cameras on for this session, we might do like a more interactive thing. So very excited to introduce Dr. Mauricio Santillana from the Harvard Medical School. He is a physicist and applied mathematician with expertise in mathematical modeling and scientific computing. He is an assistant professor at the Harvard Medical School, a faculty member in the Computational Health Informatics program at Boston Children's Hospital, and an associate at the Harvard Institute for Applied and Computational Sciences. Mauricio enjoys working with clinicians and public health officials in the design of decision-making support tools. So go ahead and start us off on this.
Thank you, Jess, and thank you to the organizers for the invitation. And nice to meet you, everyone. I hope I know I'm the last person in the day, so maybe you're exhausted already, but hopefully, I'll be in storytelling mode rather than theorem proving mode. So so we'll see. Let me first, acknowledge the fact that a lot of the work that I will be showing you has been done in collaboration with a lot of people. And so some of these are my students, postdocs and collaborators. Tiggy is one of my collaborators, by the way. And yeah, many people. So wanted to show you faces so that, you see that I'm not working alone. And these are some of the keywords for those of you who have a background in quantitative science or sciences. These are the keywords that come up frequently in my day-to-day. And, with all you guys were probably born already in the era when mobile phones were all over the place. And as you know, by using them, you're in some sense agreeing to being tracked and monitored. So you don't need to get a COVID-19 vaccine to get a GPS inside your body. It's meant to be a joke to wake you up. There's a whole field of research which is based on these digital traces that we all leave as internet users, or just by having a phone in our pockets. And so people call that biosurveillance. So it sounds like someone is monitoring you, and it's true. So you should know. And the goal for us is that instead of using all the data that you guys leave behind, and everyone who uses computers and phones, all these big companies use them to get richer. And we aspire to instead use similar techniques in the hope that we can be helpful to, help make decisions in the public health domain and healthcare. And so to get into the topic, I like showing these spaghetti plots where I'm showing you different epidemic curves. And so the x-axis is time, and they're actually week numbers, and the y-axis is showing us disease activity, specifically for influenza for the US. And as you see, the different seasons or different years are in gray, and one is highlighted just for the purposes of communication right now. And so as you see, there's variability in the intensity, the timing of the peak, and the onset of outbreaks and so on. And you're now very familiar with this because we've been living in a pandemic in the last 2 years. And so as you may have seen, knowing what's happening right now is already a challenge and can be thought of as a forecasting exercise, given that information is lagged due to multiple reasons. But one of them, as you know, when you may suspect you have COVID, you go and test yourself. That test is sent to a lab analyzes it, sends you the results, and then that result is stored somewhere. So it takes time for that process to happen from the moment you suspected perhaps you had COVID, and then until you get a result. So that lag introduces this, gap of knowledge where we don't know what's happening right now. So that's what we refer to as nowcasting. That means estimating what's happening now for a specific disease. And then people frequently want to know what may happen in the near future, meaning, is the pandemic going to get worse tomorrow or a week from now or 4 weeks from now? And then, the bigger questions are, is it going to affect a large proportion of our population? When is it going to peak? Perhaps because hospitals want to know at what point they, may be able to go back to normal, after a peak, and so on. And as you may suspect, the exercise of monitoring and eventually forecasting disease activity can be done in multiple spatial resolutions. And, we humans tend to, live in human designated areas, yet diseases, do not necessarily respect boundaries that we imposed on ourselves. And so, we're limited by the surveillance data that we have access to, that's typically collected by healthcare-based services, such as labs, hospitals, and so on. And so, from that perspective, then we build models or monitoring systems that can tell us what may be happening in different spatial resolutions. That's the bottom line. And this, I always put this plot here to remind us that any exercise in terms of trying to forecast what may happen in epidemiology is inherently challenging. And this is not to say that weather forecasting is simple, but in this plot, what I'm showing you on the y-axis is our ability to predict, say, temperature in a given location. And the different colors show you, how far into the future we can do this. And so this x-axis shows you time. And so here, what this plot shows is that over time, we have gotten better and better at producing, say, 36-hour forecast, and, with accuracies in the 85%. That means that 8 out of 10 times we get it right? So that's good. Whereas in contrast, if we are doing epidemic forecasting, if we forecast that a lot of people may die tomorrow, one at least would expect that the population would react and would probably take action. And if they actually take action, that means that the trajectory of the epidemiological outbreak that we may be monitoring and forecasting may change in response to any expert or anyone doing or performing forecast and communicating this forecast to the general public. In other words, there's a feedback effect in epidemiological forecasting. It hasn't been very present in COVID-19, I'm sad to report. That means that we have alerted governments and public health officials about the imminent outbreaks happening with the great strength, because we have witnessed how they have happened, say, in other locations prior to the US, for example. And instead, unfortunately, during COVID times, the response has become a political choice rather than a public health activity. So to give you a sense of, the way we normally think of these projects, we use multiple data sources. Again, as I said, digital traces, namely how people search online for information, assuming that, if somebody, has been in touch with another person who they suspect was sick, they may start wondering what are the symptoms of the disease that they suspect they were in touch with. And so they may search for, like, what are the symptoms of dengue fever or COVID or flu, etc. And they may tweet, I have a fever, or my close friend has a fever, he may or she may be sick. And so we track what people are saying on Twitter. Also we've monitored what people access on Wikipedia, how clinicians search for information to, say, adjust dosage for different medications, multiple data sources. And we also care about how the weather may affect as you know, for influenza, we know that it is easier for influenza to be transmitted in drier and colder environments. And so for COVID, we've studied that as well. We also look at where people are moving from and to in real time to see if that could give us a sense of where, if there's an outbreak in point A and there's a lot of movement from point A to point B, we may expect to see lots of cases in point B in the near future. So, so we have learned a lot in terms of these methodologies in studying influenza and influenza in rich nations. And then we've shown that it's possible to use many of these techniques to monitor influenza in developing nations, for example. And also we've shown that some of these techniques that we use, again, monitoring digital traces, can be used to track emerging outbreaks such as COVID and other novel diseases. So let me give you a tour real quickly on how I got interested in these topics. And so originally I was interested in seeing whether we could use information from all these social media conversation that's happening, and if we could map that into an epidemic curve, such as the ones that you have seen with COVID. And so the idea was that because social media is real time, then we could assess, the gravity of a pandemic or an epidemic outbreak or a pandemic like the one we're experiencing before, labs confirm that people are sick. And so, and if you choose to fall asleep during the next minutes, probably just I want you to pay attention to this plot, because this is a summary of what we do in terms of forecast, and this is showing you flu forecast that we send to the Centers for Disease Control in the US. And what this plot shows you is what was observed. So the black line is running in real time, and the red is what we send every week to the Centers for Disease Control in terms of what we expect will be the flu activity in the coming 4 weeks, right? So this summarizes the product, right? Like what it is, what we produce and send to public health officials, if that makes sense. And so I'll tell you how we do this, and then I'll show you that these techniques are also possible to be deployed for other diseases. And here is a preview. So basically, we look at different data sources, we extract a signal from them, and then we produce, a prediction. And as I said, I'll show you probably very briefly that these signals can be also seen in emerging outbreaks in other regions of the world. But first, maybe some of you are old enough to have heard the tool that Google implemented called Google Flu Trends. I don't know if anyone remembers this, but so basically Google decided that to study, and people had done this with using Yahoo, which was a search engine at the time, and maybe you've never heard of it. But the bottom line is that people hypothesized that if you counted the number of people who were searching for, so the word, say, chicken soup or Kleenex or cough syrup, etc., and you aggregated those numbers, you would see a signal that would probably track the number of people who were sick with influenza. And they did, and they showed that retrospectively, if you see in this plot, they said that, they were showing the number of cases of influenza here, according to the CDC. And then this solid curve showed the patterns of searches on flu-related terms. And so the idea was, and this is a plot produced by my team, that, so if you look at this black line, that's the activity of flu in South Africa over time. And in red are the proportion of people searching for the word bronchitis. And so as you see, there's a clear, relationship there that could be leveraged specifically because the red curve is known at least a week or two before the black. In other words, the information on how many people are experiencing influenza takes time because of testing times and so on, whereas the red is available immediately. Does that make sense? So and so this is another way to visualize that, that anticipation or nowcasting effort. And so Google deployed this method for the US and for multiple other regions in the planet. But very soon after they deployed it, they ran into trouble. They basically couldn't anticipate the H1n1 pandemic. This happened in 2009. And again, you may not remember this, but it was a mini pandemic, compared to COVID, but it did affect multiple countries. And basically their systems, Google's systems, missed the whole thing. So that was bad. And then they took some time, they fixed their methods. And again, in 2013, their methods predicted more than 100% more cases than actually happened in the US. So people lost confidence in this big data as a way to inform epidemiology. And so lots of news saying, this is bad science and one should stop looking at these solutions. At the time, I had an undergraduate student at Harvard, and he was very interested in seeing if we could improve their method. So he thought, I think there must be a way to use the data better than they did. And very soon we identified that, in fact, Google never shared their input information. So they had a system that needed input information to produce predictions. They never shared their input. Instead, they shared some low quality version of that. And so we said, well, if we can implement a model where we mimic their approach, and then we proposed another model that we think is better, and it looks better in terms of predicting, even if it's not as good as the actual predictions of Google, we will have shown that there's potential to improve their method. And to our surprise, even with this low quality data, we proposed a method. And this method is shown here in this plot in blue, and the black curve here is represents the observed flu activity. The dashed blue shows you what our methods anticipated would happen, and dotted red here shows what Google flu trends, what Google's approach was estimating. So even with low quality input, our methods were superior in terms of performance, even in tracking flu activity then. And we were happy that actually Google acknowledged that our methods were better than what they had, and they in fact implemented them as a way to improve their tool. And then they kept working hard, and they published another paper showing that they could even improve the model that we had proposed. And we were still stubborn, and we said, well, we can even do better than whatever you did. And so we started, having like a, healthy scientific race. And the way I tell the story is that we won the battle, because after this, they contacted us and they said, you know what, we're going to stop doing this. And if you want, you guys should just take over, because we're done. And so at the time we felt like, oh, we checkmated Google. And maybe we did, but the real reason why they stopped doing this is because they were getting really bad press. They couldn't make money. And so they said, let the academics do that work. So this is how I got engaged with this, use of digital traces as a way to monitor outbreaks. And so, as I said, Google stopped doing this at the time, and we took over. They gave us access to their low quality data, and they said, we will not give you access to good quality data because you already told us that you don't need it because you have super good methods. So in a way, we kind of set ourselves up for not getting the good quality data. But anyways, what can we do? But we changed the approach, and we decided that we had to collaborate with people from the CDC as a way to, better understand what they needed, what was useful, rather than proposing a technological solution to a problem that we didn't know we didn't know what kinds of questions they had and how we could really help them. So we teamed up with the CDC and suggested to them. At the time, the CDC was, all the people at the CDC were obsessed with finding the best model to do nowcasting and forecasting. And, was working with other students and we were showing that there were other data sources that were really good at monitoring flu, including what clinicians are searching in real time and the way people actually report their symptoms via some apps that you may have heard in your life. And also, there's some companies that are in charge of managing the electronic health records of hospitals. And since they are cloud-based, they can produce reports really quickly in terms of how many people are showing up to the hospital with a fever, for example. And so they can tell us in real time, how some diseases may be evolving. And so we actually wrote papers to show that any of these data sources were better than what Google Flu Trends was doing at the time. And the CDC folks were like, yeah, whatever, but you have multiple methods, just send us the best one and just quit, we don't care. Just tell us what's gonna happen, right? But at the time we were also working on something that is well known in when you watch Netflix, and then you open Netflix, depending on the day of the time of the day and the day of the week, you may notice that it suggests you to watch something else. It's different, right? So in 2008, I think Netflix had a competition with multiple mathematicians. I was asked to participate. I didn't, but they said we want to know what our clients want to see in a given point in time and day, right? Or in a given point in time, right? So multiple teams participated in this challenge at Netflix. So they shared a lot of data. And interestingly, at the end of the day, they realized that the best model that could predict what a user wanted to see was not the output of a single model, but it was the output of different models. And, and if you're interested in finance, that's very well known in finance. So basically we said, why are we not doing that, right? We have multiple predictors. Let's combine their strengths. And so again, the CDC was obsessed with us sending them our best results. And then we wrote a paper showing them that if you have multiple predictors and you combine them using machine learning, then you can increase the correlation with your target. That means this is one metric that you're doing things better. You can reduce your error in your predictions. And so we said, instead of, just showing the best results from the best model that you think you have, you should be looking at multiple models and, computing ensembles of them. And at the time, they said, well, sure, it looks good, but how do we implement this? And then some of my colleagues actually took over and they started running ensemble methods. And I think it's been like 4 or 5 years. So it was the next year when the methodologies like this became the way people monitor flu activity in terms of forecasts. Good. So let me see. We've done a lot more in terms of flu. Again, flu is our kind of lab because we have a lot of data for multiple decades. So this is helpful. And then, as I mentioned to you, we decided to, also look at where people are moving to and from. So we started looking at patterns of human mobility. And we showed that, in fact, if there's an outbreak in a nearby state, then the likelihood that your state will experience an outbreak is higher. And by using that information, we managed to improve predictions. And I'm flying through my slides. I hope I don't make you dizzy, but and this is just an example of how to use Twitter. But as I said, this is just storytelling mode. So I will not bore you too much. But another important question that the CDC had was, okay, you guys showed us that you can tell us the national activity and state level activity, how it evolves and so on. But we know that decision making happens at the county level or city level. So that's where we really need help. So they said, can you implement your models to track and monitor flu activity at the city level? So we worked with the Department of Public Health in Massachusetts and the Boston Public Health Commission. And we showed, in fact, that all these methods we had explored could be deployed at the city level for Boston. They were really skeptical when I told them we were using Google search activity and tweets and so on. And so they invited me to give a talk at the Boston Public Health Commission. And when I arrived, I started with my slides, we use Twitter, Google, and immediately everyone stood up and they said, you know what, thank you for coming, but we're really not interested. So I skipped to this slide and I said, look, we can produce these predictions 1 week ahead of you. So the red curve is what we can produce, and the black is what eventually is seen 1 week after. What do you think? And everyone sat down and said, like, okay, keep talking, right? And I showed them, well, these are our predictions 2 weeks into the future. What do you think? And they're like, okay, let's talk. And then, they stayed. So, but that was the environment at that time was really, they had developed an allergy towards any of these big data approaches, right? Anyways, so let me get you a bit dizzy here. So later we showed that we can even anticipate how many people are going to show up in the emergency room at Boston Children's Hospital 2 to 5 days before it happens. Let me skip ahead, and then of course there's the fever that why are you not using deep learning for this, right? And so one of my former students, Emily, she told me, look, we need to use deep learning, and I discouraged her from doing it. But eventually she showed me that deep learning could be useful. And so we ended up writing a paper on this. If you're interested, I invite you to read a bit on this. And then I don't know if Tiki, is Alex Vespignani going to give a talk, or somebody from his lab?
No? We have Jess. She's one of the mentors.
I see. Oh, Jessica
for the project
Davis.
groups. Yeah, Jessica Davis.
Yeah. Mm-hmm. Well, this work actually, this doesn't involve Jessica, but what also this folks from the CDC, they love SIR models, and I suspect you guys have either heard about SIR models or will hear about SIR models. And so they said, well, but you do this machine learning statistics, but we really want you to talk to our experts on SIR models because they are the best models. And so we've done that. We've collaborated with some folks who are experts in SIR models, and we've shown that we can improve their methods with our data sources and machine learning and so on. So bottom line is that it's been fun, and it's been really nice to work with public health officials, computer scientists, epidemiologists, and so on. And then, perhaps I should transition, let me look at the time. I should transition into telling you that, we have extended some of these methods to Latin America, to some African countries, and shown that there's some potential in using these data sources outside of the US, and also in the context of emerging outbreaks. I won't dwell here too much in the interest of now switching to COVID-19, which you may find interesting. And so let me skip all this. Tick. Sorry. Okay, COVID-19. Right. So COVID-19, you are one of the generations that has been probably you have been affected really terribly by COVID-19 in terms of the disruption to your lives, including this conference, right, that is happening virtually. And so, we started studying COVID in Wuhan when it first started. I remember I was looking at this, we were monitoring activity of COVID-19, and then, we started seeing one case trickling in another country, and two, and then And then you'll see that eventually Italy started like exploding as in the same way that Iran. And I think it was early February. And then we said, holy cow. We actually used some other words, and we realized this is going to become a bad pandemic. And so I remember I was asked to brief the Department of Defense in mid-February, and they asked me, do you think it's going to be bad? And I told them yes. It was interesting that our politicians said that, who could have known, right? I mean, they knew, the army knew, right? Everyone knew. But anyways, but what was really concerning is when we saw this plot. I think this was in March of 2020. We realized that we had COVID cases all over the country, and yet the number of cases that had been reported were still in the thousands, but they were really, really widely spread. So this gave us a clue that we were really not capturing the true number of cases. I mean, everyone suspected that, but the question was, how bad are we missing the true cases? And some of our friends in Columbia University had written this paper where they had suggested that about only 14% of cases had been documented, and that we were missing in China about 86%. And so we said, well, if this is an iceberg, how deep is the part we're not seeing? And we knew that, different policies were going to be implemented based on this. And so we worked really early in the pandemic, trying to estimate what people call ascertainment bias. So that means how many cases you're really picking up, but compared to what you should be picking up. And one of the shocking results we found is that, according to our analysis, based on all these data sources that I told you that we set up for influenza, suggested that in some states, most likely the number of infections was about 50 times larger than what they were reporting, which is bad, right? It's bad because instead of, experiencing 300,000 cases at this point in time, it was April 4th, we thought that there were already like, 5 to 10 million people infected, right? So that was, very, very concerning. And this is another way to visualize here, state by state, what we suspected was happening. And what we were using were exactly the same surveillance systems that we had deployed for influenza. So that was very useful to have had that experience in the past. And so again, this emphasized the utility of these alternative ways to monitor disease activity. And let me see. And then, we said, well, we have all this machinery to track Google searches and tweets and right? So can they be useful? And again, we involved many, many collaborators here. And so we decided to start plotting the time series of all these data sources, including human mobility, clinician searches and thermometers, right? Like they call them smart thermometers, but it's nothing more than a thermometer that has a Bluetooth and syncs with your phone, right? And so this is one interesting plot where this is for New York, and what you see in the top row is the information that came from healthcare-based systems. That means the blue is deaths confirmed, right? But due to COVID-19, the gray, which is right here, is the epidemic curve that you would see when you access the Johns Hopkins dashboard or the New York Times or whatever you see, right? You would see the gray. And yellow was a signal that we created based on the discrepancy between people who were showing up to hospitals with flu-like symptoms, and then the discrepancy between the signal that those people may have been infected with influenza. In other words, we knew that by March, the number of people experiencing influenza was really decaying, and yet people with flu-like symptoms was increasing in hospitals. So there was a discrepancy, and that's what this yellow line is. In the middle here, again, each column is a different snapshot in time of what was known. And in the middle one, we have these alternative data sources, and you see this L shape, right? Like looking like this, where, you know, the models that our collaborators at Northeastern were deploying, they were seeing, they expected to see a lot of cases. We were seeing big anomalies in people with fever, lots of people on Twitter saying I'm sick, and Google, people using Google search to identify COVID symptoms, like it was starting to go up. So by March 13th, we suspected things were really bad. And in fact, I think it was March 12th when the Boston mayors invited me to testify, and the army showed up and the governor showed up, and everyone was in a big room, social distance. And they said, so are things gonna get bad? And we said, yes, they're gonna get bad really, really quickly. In fact, we think they're already really bad. And they said, well, we're not seeing any signals in this data, right? And we said, yes, you're not, but look at these signals, right? And they're like, well, but, you know, is this really true? Like, have you validated these methods? And we said, well, we have validated them for other diseases, not for this one, but really, really, we are very concerned. And, you know, by March 23rd, when this L was started to be seen in the case counts, our methods were just exploding exponentially. So we felt like by March 23rd, we said, no, now we're completely sure that there's a full-blown outbreak in Boston and in New York City. And of course, they were seeing cases increasing. And then, of course, hospitalizations started going through the roof. And you know the rest of the story, right? So, but interestingly, our public health officials and decision makers in the city, the next day they shut down Boston. They said, you know, full lockdown. Everyone, like, they gave 2 days to people and said, like, everyone stays home. So there was a good reaction. I should say, I should not complain about their response, to be honest. And here's another way to see this, right? Like, these are the traditional data sources, namely deaths, cases, and this, I was telling you, the discrepancy between flu-like symptoms and infections due to influenza. And then, you know, here's these other data sources that also have like what looks like an epidemic curve, but, you know, with an onset that's typically earlier than the actual cases and deaths and so on, right? So we basically were wondering, so if we can anticipate outbreaks in the future, how many days ahead of time can we anticipate them? And so these plots are designed to quantify which data source, you know, produced an early warning before this same signal was observing either the signal of deaths, cases, or this one we call excess ILI, influenza-like illnesses. And so we were seeing that even with 3 weeks ahead, we could anticipate these outbreaks. And yeah, so I won't go much deeper there. But interestingly, so we now have deployed a system like that for COVID-19 for the county level, and you know that has proved to be useful for. It was originally conceived for clinical trial identification for locations where Johnson & Johnson could deploy their clinical trials, but now we're working with the CDC to send it their way. And then, you know, also these data sources, we decided to explore how they could inform, you know, how the pandemic was affecting different social groups. And we had a lot of data for Santiago de Chile, which is the capital of Chile, a country in South America, and, you know, collaborating with all these people and friends that Tiggy is familiar with. You know, we started realizing how bad things were in terms of the disparities, right? So here we're showing in green rich regions of the city, and the darker the red, the poorer the region. And this, they call them, I'm blanking, but think of municipalities, right? And so they're also organized from highest, like wealthiest to to poorest, right? And the colors have like reflect the total number of cases and deaths as a function of time. And as you see, it looks darker here in the lower areas, right? And you know, using mobile phone data, we could see that regions in the poorer end could not respond very well to lockdowns, mainly because their livelihood depends on selling things on a daily basis to, you know, from one person to the next, whereas the wealthier areas, you know, this is the decrease in mobility on the y-axis, and this is time. And so you see that when the lockdowns were implemented by the Chilean government, you know, the decrease in human mobility was more pronounced in the wealthier areas because, you know, wealthy people have more privileges to stay at home, right? And unfortunately, you know, we saw also that mortality, and I don't know, I think I may have it here. Yeah, so mortality here, you see the y-axis is say a rate of deaths, and then in the x-axis you see from poorer to wealthier, and you see the clear impact on the different social groups being very, very different. So again, this is highlighting the use of novel data sources to inform, you know, in a way, you know, the causes and I mean, the story here is more complicated, and we have a nice paper documenting this that I invite you to read if this is of interest. Let me see. Okay, and then this is, I think I'll wrap up with this one. This is work with some collaborators from Harvard, and you know, this is you know, maybe I don't know if you've seen a plot like this, but here are, you know, on the x-axis you see the number of so you see counties that voted you know, for Biden, the majority towards the left, or the majority voting for Trump during the 2020 elections. And you see the rate, the death rate on the y-axis in 3 different time periods. This is during the beginning of the pandemic. And what you see here is that there appeared to be higher mortality in Democratic counties, which in fact, I'll show you, we did a lot more analysis here, but you know, the first most hardly hit regions in the US were in well-connected urban areas, which happen to be Democratic, right? So that's why you see this. In, you know, towards the summer of 2020, the first year of the pandemic, this pattern started changing a bit. So a lot more regions in rural areas started being affected. And then, you know, from October 2020 to February 2021, that means last winter, not the one that we're experiencing now, but the previous year, you see this like dramatic difference in mortality just based on political partisanship. And of course, this figure, you could say, well, there are lots of confounding factors here, right? And so, you know, this is another mortality, another way to see the same information with more recent data all the way to December of last year. So 4 weeks ago. And you see you know, the darker red are Republican like counties, and blue are Democratic counties. And then you see how mortality has decreased. This is probably in response to vaccination efforts. And, you know, so in this paper, we basically said, okay, those plots are interesting, but let's really find out if you control for socioeconomic status, for education, for multiple socioeconomic indicators and vulnerability, you know, indicators, such as the ones that are shown here, you know, is there a way that you really, when you look at the same income, right, and you see, well, what the political ideology was dominant in that county, do you still see these differences in mortality? And the answer is yes. So this highlights the role of our politicians really not helping the general public see the pandemic as a public health issue, but rather as an issue of identity, of political, affiliation to political ideologies. I guess that's the bottom line. So I'll stop there, Tigi. I think I'm at 6:45 and I should stop. So yeah, I'll stop right there.
Great, thanks.